Speaking of patient safety, know your vascular access device. Before using any type of medical device, including infusion devices, it is imperative that the clinician have a thorough understanding of the technical specifications and instructions for use. All catheters, all needleless connectors are not alike.
Take a moment to contemplate these questions. This slide provides basic definitions of catheter types. PICCs are long, central lines usually placed in upper arm veins with the distal tip residing in the lower one-third of the superior vena cava, or SVC. In contrast, midlines are long peripheral lines with the distal tip residing in the shoulder area. Midlines are only appropriate for a few specific infusions, while PICCs are appropriate for most infusion therapies, especially those that are longer term. Tunneled catheters are also appropriate for most infusion therapies and are particularly well suited for long-term needs. The pediatric population uses these catheters frequently. Broviac is one type of pediatric tunneled catheter. Non-tunneled catheters are used for short-term infusion needs and are often placed emergently. A triple or multi-axis lumen subclavian or IJ central line is an example of a non-tunneled catheter. The clinician must ask the following prior to using any IV device. Where is the catheter tip? Where is the catheter inserted? Is it valved or non-valved? Is it power injectable? What type is the needleless connector? Catheter tip location determines what types of infusions can safely be administered through them. Malpositioned catheter tips can have devastating consequences. Therefore, PICCs placed by IV therapy must be released for use only by an IV nurse, and significant changes in external catheter length must be discussed with an IV RN. At Fletcher Allen, evidence-based practice and policy dictates that optimal tip location for central lines, other than dialysis catheters, is at the junction of the lower SVC and the right atrium, otherwise known as caval atrial junction. Remember, IV therapy placed PICCs can only be released for use by an IV therapy nurse. Midlines are rarely used. These are the most common sites for catheter placements. Infusions can also occur through devices placed through the translumbar hepatic portal or intraosseous approach, but these are not common. Access devices can be valved or non-valved. It is important to understand the difference. Non-valved access devices do not contain incorporated valves. Non-valved access devices may require heparin to prevent occlusion and maintain catheter patency. Non-valved access devices have clamps and should be kept clamped when not in use to prevent blood reflux, which can lead to occlusion, air embolism, and exsanguination. May occur when a line is left unclamped. The amount and frequency of heparin is dependent upon the age of the patient and type of access device used. Valved access devices contain an incorporated valve at either the proximal or distal tip. Because these devices have reduced risk of blood reflux, they do not require heparin flush. Generally, valved access devices require saline-only flush. An implantable vascular access device, often called an IVOD or port, may be surgically inserted. These devices are intended for patients who are receiving long-term therapies such as chemotherapy. They are placed completely under the skin in a subcutaneous pocket. They are accessed through the skin using a non-coring needle, for example, the Huber needle. The port is usually located in the chest. Peripherally placed ports in the antecubital area attached to a centrally placed catheter are less common. When a port is not in use or not accessed, monthly flushing is usually required to maintain patency. When a port is in use, the non-coring needle should be changed weekly and the device flushed. Power injectable access devices use unique engineering to allow for injection at a maximum pressure not to exceed 300 pounds per square inch or PSI. Power injected contrast for stroke code CTs are often injected at a rate of 6 milliliters per second and higher than 300 pounds per square inch. Until we are able to place catheters FDA approved for that rate, power injectable catheters may not be used for stroke code CTs unless the rate is reduced. The plain power PIC is a non-valved power injectable access device. The solo power PIC is a valved power injectable access device. The solo PIC valve is located in the proximal end of the lumen near the needleless connector. Some power injectable access devices also allow for central venous pressure monitoring, such as barred power PIC and barred solo power PIC. To conclude this section, Know Your Vascular Access Device, we'll discuss some things clinicians need to know about needleless connectors. Take a moment to contemplate these questions. Needleless connectors were originally designed and manufactured to protect clinicians from needle stick injuries. They may appear to be simple devices, but have complex design issues that may make some more prone to cause occlusion and others more prone to cause infection. In 2007, there were 7 different needleless connectors in use within Fletcher Allen. These indicated negative, neutral, and positive displacement connectors, each with different technical characteristics and flushing requirements. The Jeffords Quality Institute Central Line FEMA chose to implement one standard needleless connector at Fletcher Allen Healthcare. We have changed from the Smart Site needleless connector to microclave. This connector has little or no blood reflux upon disconnection, while negative displacement connectors, such as the Alaris Smart Site, have significant reflux. Microclave requires a simple and familiar flushing technique and is FDA approved for saline-only flushing. Although at this time we will continue to flush non-valve catheters with heparin flush per the Introdoc policy related to central venous access devices. Some positive displacement connectors have been shown to have higher rates of bacterial transfer through them, more dead and priming space for biofilm and fibrin to form, and have been implicated in increased catheter-associated bloodstream infections in certain studies. They also require significant changes in flushing technique.